Okay, great. Thank you so much for joining us tonight for Parathyroid Awareness Month and a really exciting webinar with some experts in parathyroid surgery. So based on a lot of popular demand, we are presenting tonight behind the scenes surgical decision-making in parathyroid operations. So the American Association of Endocrine Surgeons is really excited to host this patient-centered webinar in conjunction with our patient advocacy organization, the Paratroupers. You can find the Paratroupers with us on Facebook at the open page called Parathyroid Disease Support and Awareness. And then our patient advocacy group runs a really important closed group by the same name. I am Dr. Lilah Morris-Wiseman. I'm an endocrine surgeon at Johns Hopkins, and I'm so glad you're joining us. Whether you've recently been diagnosed with hyperparathyroidism and are preparing for surgery, or you just want to know more about the options, this webinar is for you. We know the operating room sometimes seems like a black box for patients, and we want to make it easier to understand what actually goes into planning and performing a successful parathyroidectomy. There are many ways to do this, and these surgeons here are experts, high volume parathyroid surgeons, so we want you to know what's out there. Dr. Cunnungham, do you want to introduce yourself?
Thank you. My name is Carrie Cunnungham. I'm the section head of endocrine surgery at Massachusetts General Hospital, a subsidiary of Mass General Brigham.
Great.
Yep.
And then
I'll tag the next person. Michael?
Yeah, Michael Ye here from UCLA. Hi. David.
Hi, Dave Schneider from the University of Wisconsin. Sorry, Abbey.
Thank you. Abbey Fingeret, University of Nebraska. And Lindsay.
Hi, I'm Lindsay Quo. I'm an endocrine surgeon at Temple University Hospital in Philadelphia.
Great. Well, let's start by having our panelists talk a little bit about what happens before the operation. And so we can sort of talk about what imaging each of you use and make sure we're kind of covering all the imaging. Dr. Ye, do you want to start and talking a little bit about ultrasound and specifically surgeon-performed ultrasound?
Yeah, we love doing ultrasounds on all of our patients. Really just no substitute for getting that set of three-dimensional images in your mind. We use it first, and then we're able to find about, I would say, 80% of parathyroid adenomas on ultrasound. In our back pocket, we always have a parathyroid 4D CT scan, but we only pull that trigger in the event the ultrasound is negative.
Great. And what about Dr. Schneider? What do you use? What are your thoughts?
Well, gosh, I totally agree with Michael. I think ultrasound is our first and go-to imaging modality. And then if the ultrasound is negative, I really ask myself, what is the probability that this patient's going to have a single adenoma? If that probability is high, then I'll get something else, like the 4D CT scan is probably my next go-to. But if the probability that they have a single adenoma is lower, I may not get any other imaging, because all imaging is really kind of geared towards finding that single adenoma. So if they're more likely to have multi-gland disease, then you're kind of just doing a lot of stuff to try to find something that's just not there. That's kind of my philosophy.
So you are you're operating in patients sometimes when you don't see anything in imaging?
Absolutely. If we think they have multi-gland disease, the treatment is still surgery, and we're still 97, 98% successful in curing those patients. It's just the imaging isn't going to help you in that scenario.
Great. And what about Dr. Quo?
Yeah, so I, again, totally agree with Dr. Ye and Dr. Schneider. Surgeon-performed ultrasound is a great first step. For me, again, in some situations, I really do prefer another imaging modality in addition to that. My imaging modality choice is a 4-dimensional CT scan, which sounds really fancy, but really what it is just a regular CT scan where you get a set of images without any contrast, and then contrast dye is injected, and then we get 2 more sets of images at varying time points. And this can help show an abnormal parathyroid gland. On the first set of images after the contrast, the parathyroid glands will light up, or the large ones, excuse me, will light up, similar to the thyroid. And then on the second set, they'll actually sort of be a little bit darker, and that can be really helpful. It also provides a sort of 3-dimensional view of some areas that you may not be able to see on an ultrasound.
I'd like to I can't help myself. I'm going to hop in as the moderator here. So I do things slightly differently over time. I agree with everything, but it's sort of frame it differently to my patients, which is I do my own ultrasound at the bedside because I think there's nothing better than a dynamic ultrasound, right? Than looking at static images that are saved. If I see a clear, big gland, I'm done. Like I don't look for anything else. I don't get a CAT scan. Now that's definitely different from some of my colleagues at my hospital. But I also use the 4D CT to make sure there isn't something anywhere else, right? That's more, I try to frame it like that. And just to be really clear that negative imaging does not mean you don't have primary hyperparathyroidism that is diagnosed with the serum levels, the blood levels, both being elevated calcium and PTH.
Yeah, Dr. Cunnungham, I'm going to add to that. So I agree with all of my colleagues. The diagnosis of the disease is based on blood tests, and the imaging is helpful to decide where to start the surgery, but not whether a surgery should be offered or performed. So I, in particular, am very cautious about using the term negative when I discuss the imaging. I call the imaging non-localizing. And all that means is that it didn't tell me where there was a single or solitary adenoma. The majority of primary hyperparathyroidism is one enlarged gland, but depending on your practice, 15 to 25% of people can have multiple glands enlarged. And in those situations, the imaging isn't going to be helpful. I also prefer surgeon-performed ultrasound. And then 4D CT is my next test if that ultrasound hasn't identified a solitary adenoma. But there are some people who are not eligible for a 4D CT. It does require intravenous contrast. So if you have a severe contrast allergy, you may need a different type of test. There is a test called a sestamibi, or a nuclear medicine 99 technetium test, which is also a radiologic study, which involves an injection of a tracer and then imaging typically in 15 minutes. And then some studies are performed a little bit later in 90 to 120 minutes. And that can provide some helpful localization for patients who cannot get a 4D CT.
I wanted to make sure that our attendees can ask questions through the chat or the Q&A function, and we're happy to answer questions as they come up. Does anyone use PET scans or want to talk a little bit about PET technology?
I can happy to chime in on that. So PET scan is another type of nuclear medicine test, which is a functional test. So it's looking for activity based on the type of tracer. Many people have heard of PET scans related to cancer care, and those are a type of PET scan that use labeled glucose. There's another type of PET scan called choline PET, which is used for prostate cancer, but also has uptake in abnormal parathyroid glands. And this can be a very useful test for patients who have had prior unsuccessful parathyroid surgery, or people who have had non-localized imaging that are looking for a little bit more information. It is a very expensive test, and so it's not recommended for people who wouldn't absolutely need it, and it's only available in a very small and selected number of locations. And so if that's something that that you as a patient may be interested in, it's an important discussion to have with your surgeon, with the understanding that in many cases it's not necessary, and in the vast majority of cases it's not necessary.
We switch a little bit and talk about anesthesia and sort of the operative setting. Dr. Ye, when we think about what patients can expect the day of surgery, what types of anesthesia do you use for parathyroid operations, and how do you decide what's safest or what's best for a particular patient?
Yeah, most of our patients at parathyroid surgery do have general anesthetic. They're fully asleep, and they do have an inhaled anesthetic. We've tried all sorts of different types of anesthetics at UCLA, local with sedation. General anesthesia was something called an LMA, or a laryngeal mask airway, which is like a soft balloon that sits in the back of the mouth and helps people breathe. And then some patients have a general endotracheal anesthetic. I don't tell the patients in advance what they're going to have. I don't really think it's my place. I let the anesthesiologist examine the patient, look at their airway, take a history and make an educated a decision on that, because they're professionals. That's what they do best, and I don't want to interfere with them. Bottom line is we haven't had any anesthetic complications, and I think really it's really important to trust your colleagues to do the best thing.
Great. Other panelists want to chime in about what they use. Does anyone use nerve monitoring during parathyroidectomy? Nobody.
I do. I'll talk if no one else does. Yeah.
Great.
Go ahead.
Okay.
Yeah.
So I do it. I started doing that when I came out of training into practice now 7 years ago. And that's because I wanted to make sure I was preparing myself for every eventuality. And so other people may do different things, but you can only have it sort of set up at the beginning of the operation because it has to be attached to the endotracheal tube if you are using one. You can't go in this, well, you can, but it's not really an easy thing to do. And so sometimes I will always have it available. I don't always use it for the nerve monitoring function per se, but I have it available in case I need to use it, especially if I think that there may be a foregland exploration or some other condition that maybe I want to find the nerve.
And Dr. Cunnungham, did you want to chime in about nerve monitoring?
No, I use it for any neck case, because sometimes you're doing a thyroid case, and the other day I found a big parathyroid adenoma unexpectedly, and vice versa. So I just like to have it. I don't rely on it to find the nerve, but if I'm going on the opposite side of the neck, I'd like to. So just to be clear for the people listening, we're talking about a nerve monitor, which is the nerve to the vocal fold on each side, the vocal cords. Which are little muscles that contract and make that E sound back and forth. And where all of us endocrine surgeons are, think about it, lose sleep over it, and all those other things. So the nerve monitor helps us assess the actual functionality of that nerve. So when you stimulate it in the operative field, it'll actually make the muscle contract, and it'll make a sound on that endotracheal tube. So the second thing I'll say is that I also always use general anesthesia in my patients.
And then do patients need to stay overnight after parathyroid surgery? Dr. Schneider, do you keep your patients overnight?
So we really keep hardly anyone overnight. And I realize what I'm about to say, I might be the outlier here, but we've just come up with safety protocols where pretty much everyone can go home after a period of observation in the hospital. The main risk is, bleeding or neck hematoma after any sort of operation in the neck. And so that's why we watch them for a period of several hours afterwards. The caveat is that if they live far away, or if they live in an area where they don't have access to me, basically, quickly, then we make them stay close by. So I make them stay in Madison overnight, just to make sure that if by chance they were to have a bleeding issue overnight, that they would be close by, and then they can go home the next morning. So that's the only caveat. Even though we don't keep them in the hospital, we do keep them close if they live very far away.
anyone else want to comment on outpatient parathyroidectomy? I think probably 90% of parathyroidectomy is done outpatient now. Who might stay in the hospital? Dr. Paul.
I usually tell people that if you're over the age of 80, you should stay overnight just because you're getting anesthesia, and not so much because of the parathyroid part of the surgery. But my loose rules are you have to have somebody who can be at home with you, and take care of you. And that, again, similar to Dr. Schneider, you have to be able to come back if there's a problem. So for people who may have transportation issues or who live very far away, or really anyone really elderly or who has significant other medical problems, those are the people I say, maybe we should consider having you stay overnight. There's no hard and fast rules besides having somebody to go home with, though. I did have an 84-year-old decide that she wanted to go home after surgery, and she did great. And those are, again, the loose rules for me personally.
I think we should just clarify, Lilah, that we're talking about primary hyperparathyroidism.
Yes.
If anyone in the audience, there are different types of hyperparathyroidism, and the sort that is related to renal failure, that's a different disease, and those patients will definitely be staying overnight and perhaps for a few days. So slightly different. The vast majority of what we'll be talking about tonight are the primary disease within the parathyroid glands.
Yes, absolutely. Thank you. And then we have a question from the chat about reoperative parathyroidectomy, which I think is a really important question. When patients have already had one parathyroid surgery and they have imaging that shows different things, how do you decide when to reoperate? Do you need multiple studies showing the same target? How do you all think about that? We can start with, how about Dr. Fingeret? Do you want to start with that?
Yeah, I'll start with the first and most important decision is a high volume parathyroid surgeon in a reoperative situation. Without getting into specifics about a certain individual's disease process, there are sort of two types of reoperative parathyroid surgery. The first is a recurrence of disease after a time frame when that person was previously cured. And so typically that's someone who had one adenoma that was successfully removed, the calcium and the PTH returned to normal. And then over time, year, 2 years, 5 years, the calcium is again elevated and the PTH is again elevated. And so that would be a recurrence of disease. And almost always that's from a second adenoma. And then there's an alternative circumstance where the first operation was not a curative operation. I see there's a chat question about intraoperative PTH, and we will get into that. But in a circumstance where an initial surgery did not identify a parathyroid that was enlarged or did not remove the correct extent of parathyroid tissue to bring those levels back down to normal, and we all define cure of this problem as a normal calcium at 6 months after surgery. And so if you're in that situation where you never had a normal calcium, now you're dealing with persistence of disease rather than recurrence of disease. And in that circumstance, it's incredibly important to have a high volume parathyroid surgeon who is experienced in reoperative parathyroid surgery. We talked a little bit about the nerve to the vocal cords, and there is a low risk of injury in a first operation in the neck, but the risk increases significantly in a second operation because now there is scar tissue around that area. Almost all parathyroids are present directly behind or very near the thyroid gland, but in a first operation, they can be evicted from their usual location. And so they might be found in an unusual place now. And that's why the most amount of information available is the best prior to a second operation. And so a reoperative parathyroidectomy in the setting of persistent or recurrent disease is one circumstance where, regardless of my ultrasound findings, I will also get a 4D CT and a sestamibi because I want all the information going into that. I also want to do a vocal cord assessment and make sure that there was no injury during the first operation to either nerve. The imaging tests are not perfect. They don't tell us every single detail, and there can be conflicting findings. So Thyroid nodules can sometimes show up on the nuclear medicine test. 40 CT scans can misinterpret lymph nodes as potential parathyroid glands. And so the best thing to do is to have a very high volume experienced surgeon be the one to review your imaging and discuss the possibilities. And particularly know that there might be a plan that all of those things need to be re-explored in the second operation, because the imaging just tells us where to start. It doesn't tell us every detail that we need.
Great. Anyone else want to add in their strategies for reoperative parathyroidectomy?
Come on, Michael. You're probably the most experienced of us all. I want to hear what you have to say.
Oh, yeah. And I noticed a question in the chat about this. Sometimes I imagine that there might be quite a few people in the audience, and that's why they got interested in parathyroid disease, because an initial operation didn't go so well, and now it's a bit of a quest, right, to get to that second operation. The way I think about it is, if you are considering to reoperate on a patient with primary hyperparathyroidism, you do so at probably triple the risk. And so the best patient to reoperate on, one, has a high calcium, certainly greater than 10.5, probably even higher than 11, right? Two, is sick, right? You have to have a motivation or a justification to subject them to the additional risk. And by sick, I mean kidney stones, osteoporosis, something is happening to them, or just feeling terrible from a calcium of 12 or something like that. And third, they have a target on imaging. And several of you alluded to that. And for us, that's almost always going to be a 40 CT. 2 times a year, we'll send somebody up to UCSF for a PET choline MRI twice a year. And then you have to do this additional assessment, right? And the assessment of what the operative strategy is going to be is a combination of detective work, what happened before, and you can't always figure that out because that information can be very reliable or sometimes very old. And then the assessment of the current state, right? So it's a combination of detective work happened before, and then the assessment of the current state, which is really looking at the imaging. And then ideally, you have a strong target and you're going to pretty much focus down your operation on that target. And something we've said in this room, but maybe not fully explained, is the fact that in an initial operation, there isn't scar tissue and a surgeon is free to move about the neck, right? With low risk, you can look at different areas, and a scarred neck, man, any looking around, you're sweating. And so you really want to focus down that operation as much as possible. There's a question in the chat about somebody with conflicting imaging. That's a tough situation. In general, some types of imaging might be a little bit more reliable than others, right? So as surgeons, we have to figure out, okay, in a conflicting data situation, which one we'll be relying more on. And for us, that's probably the CT is the most accurate for reoperation planning.
Yeah, I think that's really important, what Dr. Ye said, which is when we interpret, again, having the best first operation is the most important thing, right? Because at that time, all the anatomy we love it. We know exactly where to find things most of the time. And it is really the interpretation of the imaging. So the radiologists or the nuclear medicine doctors are the ones technically, officially reading those studies. But as endocrine surgeons, we become well-versed, at least in those imaging technologies that we use. So I'm sure all of us on this call, we perform our own ultrasound. Again, even if you've had it, we review the images ourselves for both the sestamibi, potentially PET, and especially the 40 CT. We work very closely with our neuroradiologists, and we have a parathyroid conference where we look at all of these cases. So it's very common that we have not very common, but in my practice, I guess, that we have some discrepant imaging. So that's not uncommon. It's a bit of an art form, parathyroid surgery. And I always joke with my residents that to be parathyroid surgeons, we're special breed to do the detective work.
One of the big questions, sort of thinking about surgical approaches and decision making in first-time parathyroid surgery is sort of this difference between a focused exploration, minimally invasive parathyroidectomy, 4-gland exploration. There's a question in the chat about, I want a 4-gland exploration so I don't need future surgery, recurrence. So I wonder if we can just sort of maybe go through the panel and everyone lend a piece to this conversation. So maybe Dr. Kuo, talk a little bit about your approach, focused, what does minimally invasive really mean?
Yeah, absolutely. Thank you. So minimally invasive is the idea that you are sort of doing a little bit less surgery, a little bit less looking around. Oftentimes it will involve a slightly smaller incision, although I do think for many of us, we try to keep our incisions extremely small regardless. And we make things, as I tell patients, like as small as I can, but as big as I need it to be. So a minimally invasive parathyroidectomy or a focused parathyroidectomy is the idea that you are going after a target or a single thing that you think is the parathyroid that is abnormal based upon your preoperative imaging. I will do this in certain situations, again, when I have clear imaging that shows one very clear and obvious abnormal gland. And that's really the only situation that I'll do it in. And I also will use the parathyroid hormone monitoring to make sure that the parathyroid hormone level has fallen appropriately. And that's how I know I've been successful. For really any other situation, and that for me personally, that includes anyone obviously who has non-localizing imaging, and anyone, again, for me, who has a normal calcemic or normal hormonal presentation, I will automatically plan to do a 4-gland exploration, which I know sounds really scary, but that is, again, that's our job, is to find the abnormal parathyroid glands. And this generally does not involve a huge incision. This is also something that I have a very low threshold to do if the parathyroid hormone level doesn't fall appropriately, or if perhaps I see a second abnormal gland on that one side and I think, oh, well, instead of having just one abnormal gland, now I have 2. Do I have 2? Or are there really all 4? And you want to be really sure because, as I think we've mentioned just previously, the first operation is really the ideal time to be finding what is normal and abnormal. So those are my personal practice patterns, and I'd love to hear what the other panelists also do.
Dr. Schneider.
Yeah, thanks. I totally agree with what everybody has said. I think that this question always comes up like, I just want to have a 4-gland exploration the first time around, or I really am hoping I can have a quote unquote minimally invasive surgery. So I think that, I try to really take a tailored approach and do what's going to have the highest chance of curing the patient the first operation, like we've talked about, but not cause unnecessary risk or unnecessary complications. Once you have dissected or affected or worked around all 4 glands, then you actually risk the opposite problem, which is hypoparathyroidism or hypocalcemia. And that can be a devastating problem to live with, even though it may sound like not a big deal, oh, I just have low calcium. So the approach depends on what their labs look like, what if they've had surgery before, what was done, their family history, a multitude of other factors. And then, together we make the decision, okay, are we going to do a quote unquote focused operation and used intraoperative PTH levels to help guide whether we need to do more than that, or should we just do a 4-gland exploration right at up front as our initial plan? And that, like I said, depends on a multitude of factors that come from the patient and ultimately, I guess, our judgment about what the likelihood is that they're going to have a single adenoma versus multi-gland disease.
Dr. Dr. Fingeret.
Yeah, I think this has all been really thoughtful, and this is how I approach My care, I have a phrase similar to Dr. Quo's. I say my number one goal is to do the right operation and do it safely. And my number two goal is to do it through the smallest incision that's physically possible. Sometimes to my own chagrin, turning my neck sideways and contorting my body in a variety of positions to be able to accomplish this surgery through an incredibly small incision. Whether that's a single gland focused exploration or a 4-gland exploration. I also always like to think about my current self and my future self, the current patient and this patient in the future.
Love it.
So someone had asked, yeah, so my future self really needs my current self to be thoughtful. Someone had asked, what's the likelihood that this problem is going to come back again? So when we're talking about someone who's had a curative surgery, meaning their calcium is normal 6 months after surgery, then the likelihood that they're going to have a recurrence of disease is between 5 and 10%, depending on the study population. And so 90 to 95% of people are not going to need a second operation, but 5 to 10% of people are. And if they're coming back to me as their initial surgeon, which I hope that they would, because I hope that they had a positive experience, then I want as little scar tissue in that area as possible. And so I prefer a minimally invasive or focused parathyroidectomy for all patients who have localized disease. And that means I use intraoperative PTH monitoring. And so that PTH test is a slightly different version of the test than the one you get in the outpatient laboratory because it can be run quickly. My turnaround time in my operating room is about 20 to 25 minutes. And so I will perform that focused or localized operation. I'll identify the gland. My pathologist will weigh it and tell me how many milligrams it is. If it matches, so if my intraoperative findings match the imaging that I've seen beforehand, and the gland to my naked eye looks like an adenoma has a nice purplish hue. It's a beautiful color. Whereas multi-gland disease tends to be more of a salmon or yellowish color. So if it looks like an adenoma, it has a certain weight and it matches what I saw during surgery, I actually will start closing. And so I'll put the stitches in the neck and just wait that 20 minutes for the lab. And in my experience with my review of CT imaging, 95% of the time that lab comes down as it should. And now the surgery is done, the glue is on, and the patient wakes up. In the rare circumstances where that number doesn't come down, the patient hasn't had the breathing tube taken out, they are still under anesthesia, I can very quickly and easily take out those stitches I put in and look at the other 3 glands. In my practice, that happens about 3% of the time because I wouldn't finish the surgery or close the surgery unless I was confident that that was an adenoma. Very similar to Dr. Quo, if I get in and I see, maybe that gland wasn't particularly large, maybe it didn't have that purplish hue, maybe it was under 150 milligrams, I'm going to have a much lower threshold to look at the other glands because I don't want to leave the operating room without a cure. That's my number one goal, is to do the right operation and to do it safely. And so in those circumstances, I will still send the PTH levels, but I may look at the other glands while waiting for those levels.
I just want to make one comment for the audience because I think there's a conception for a lot of my patients that a minimally invasive operation and a 4-gland exploration are widely different. I make scars that are equal on both sides, regardless of the operation. And honestly, almost every patient no matter the length of the scar, if you put it in a natural skin crease, you really can't even see it a few months later. So the 4 centimeters versus 4.5 is really, I understand it's not my neck, but they heal nicely either way. And a 4-gland exploration can be done very quickly too in experienced hands. And the one thing I do, which no one has mentioned, and I'm sure you all do this anyway, is if you're on one side, we call it unilateral. There are a lot of different names out there: focused, minimally invasive, unilateral. Really what it means is, you should have 2 on each side, right? Some people have more, some people have less. But if you have 2 on each side, let's see, you see that nice big purple colored, magenta colored adenoma, you let the pathologist take a look at it and weigh it. You're waiting for your PTH value to drop, which can happen as quickly as 10 minutes while you're still asleep. And at the same time, you're on that side, you've already dissected out this compartment. Most people I know they're sitting there like, well, let me make sure the other gland on that side at least looks normal. So in the cases that you have 4 hyperplastic glands, where all 4 of them are a little bit enlarged, what Dr. Fingeret was talking about, kind of salmon colored. If you have on one side a big adenoma and the second one on that side is normal, then it gives you even higher rate of cure because you've sort of ruled out at least 4 gland hyperplasia without going into the second side and potentially harming anything.
So Dr. Ye, can you tell us kind of what you do and whether, I know what you do, but whether whether your approach or a 4-gland exploration prevents any recurrent disease?
Yeah, great question. So I'm a 4-gland exploration guy. I enter every operation with that plan, regardless of the localization. The localization tells me where to start. I'm going to touch on some points that others have made. So I will go in. So the typical operation I do, localized adenoma, I go in, I take out that adenoma, I biopsy the ipsilateral normal, I go to the other side, I carefully examine the mirror image gland. The mirror image gland, that exactly opposite the adenoma, because there will be some double adenomas there, particularly if they're in the superior position. I try to biopsy the mirror image gland, and I look for the 4th gland and leave it alone. And usually by then, the 5-minute PTH level is back. Our turnaround time is 9 minutes, and I close. And I really loved how Dr. Fingeret says that she is always of 2 minds. She is in her present mind and she is in her future mind. I say this to every one of our fellows because there's a small chance the patient could have a recurrence down the line. Small, 1 or 2%. And then when I am my future self doing detective work on my prior operation, I want to have made it absolutely as easy and safe as possible for that person to have a second operation. And that's why I biopsy those normals. It's just a tiny little shaving, but then I know I found a normal gland there, right? And I don't always find all 4, usually, but not always. There are instances where before I find the 4th one, PTH level comes back and it drops. And I'm like, oh, the patient's cured, right? So there's a limited, you reach a point of diminishing returns in terms of your continued exploration. So yeah, I like to do that. It works pretty well. But there are many methods that work, and my advice to patients is not to get too much into the weeds about this. It's easy to split hairs about this, but the bottom line that every surgeon has said, you want a safe and effective operation. There are many routes to that end, usually through someone who's doing this regularly and doing it a couple times a week.
And then we have a question in the chat about so risks of surgery, specifically vocal injury, and then also about when you're going into surgery for parathyroid and you have thyroid nodules. What do you think? Like, do you ever take out thyroid nodules, or sort of how do you think about that when you're entering into that type of operation? Monty.
I'm happy to address that. Incredibly important that your surgeon perform an ultrasound to evaluate your thyroid gland, because that's what we're looking for. We're not just looking for parathyroid localization, we're looking for thyroid nodules, which are incredibly common. More than half of older age adult women are going to have thyroid nodules present. The vast majority of thyroid nodules are not cancerous. But sometimes information is needed before surgery, and we use very specific criteria for what thyroid nodules are concerning or suspicious enough to warrant a biopsy. And therefore, we would know going into parathyroid surgery whether thyroid surgery was necessary. It is not a circumstance where you want someone making a decision in the operating room to treat a thyroid nodule that has not been appropriately evaluated. In my practice, there are 2 types of thyroid surgery: half or whole. There is no removal of a nodule. It does not provide the appropriate information or the appropriate treatment if this does come back as a thyroid cancer. It introduces an incredible amount of scar tissue in important areas, and it increases bleeding risk. And so I would need to know that information prior to surgery to have an appropriate informed consent discussion, because while the interval risk of adding thyroid surgery to parathyroid surgery is minimal, there is a function of the thyroid. It makes thyroid hormone, and there needs to be a discussion about the likelihood of needing thyroid medication based on the current thyroid function, how much thyroid would be planned to be removed, and what's the working diagnosis. If it's a benign nodule that's causing symptoms on the same side as the parathyroid, reasonable to consider treating that with removal of that half of the thyroid, as long as the patient understands that there's a risk that they would need thyroid medication. Anything more aggressive than that, like an indeterminate thyroid nodule with suspicious features or a suspicious or cancerous thyroid nodule, that's a much more involved discussion. And so if the thyroid nodule warrants a workup with a biopsy, that would be done well before any plan for parathyroid surgery. But it is not uncommon for us to see thyroid nodules in our ultrasounds.
And is there any thought about one of the chat questions, you know, a thyroid that's really enlarged, does that limit you when you're trying to do parathyroid surgery? How do you think about that? Does it have to come out?
It doesn't have to, but it's a discussion with the patient, because it's certainly going to impact the incision size that's necessary. So goiter, a term for enlarged thyroid, which is typically benign. If you have a patient with a very massively enlarged thyroid and the parathyroid is behind it, that's not something you can do through a 2 or 2.5 centimeter incision. And so that's a discussion. And also the discussion is, I tell the patients, you make this decision now, not a decision to have a parathyroid surgery now and a thyroid surgery in a year. So if it's causing symptoms, I'm going to address and treat both things at the same time. But certainly it's possible to do parathyroid surgery around a large goiter, as long as you have a big enough incision and a strong and useful assistant.
And then what about other adjuncts to parathyroidectomy? Does anyone use autofluorescence?
We've used it. I've used it more to evaluate it and do research about it and decide how it should be used and where it's helpful or not helpful. I think that for an experienced parathyroid surgeon, autofluorescence may not necessarily be necessary. I think so. Just to backtrack a little bit, autofluorescence is using all tissue has a sort of natural admittance of certain light and certain wavelengths, and the autofluorescence is a little detector that's able to detect the wavelengths of parathyroid tissue. And so the idea is you could use a little wand or a little tiny camera and put it over your field or apply it, closely to certain tissue. And if it gives you a certain ratio or detection level, then you might think that that's overactive parathyroid or a normal parathyroid. I think the issue is that there are a lot of reasons why that number may lead you astray. So it depends on the autofluorescence of the thyroid itself, because you're sort of normalizing it to a background, or you're taking a background on the thyroid to kind of set a baseline or a background level. It depends on whether the patient has brown fat. Brown fat is fat that's just more metabolically active. People have it in their bodies, but some people have more of it. That causes the detection to be falsely positive on pretty much all the fat and all of the tissue around the neck. And so, I think it's helpful if you're debating whether something is a parathyroid or possibly a lymph node or something, or thyroid tissue, things that are in the neck that could be a parathyroid. I think it could be helpful in thyroid surgery after you've removed the thyroid to just make sure you've not inadvertently removed parathyroid tissue on it. But for all of us that do a lot of parathyroids and can find them, in our dreams, in our sleep, I don't know that, using this device is super helpful for us. But I've used it. It is an adjunct. There's certain situations where it might help you, but I don't know that it's necessarily to do it in every single operation. It's quite expensive, or it adds expense to the case as well. So that's another reason not to always use it.
What
think
about, oh, go ahead, I'm sorry.
No, it's just important. I think patients sometimes, when they ask me, well, why don't we get all these tests? Why don't we check everything? Why don't we use everything? And as you can see from this conversation, that it's very nuanced. And oftentimes, information may be misleading. So we have to steer the ship in one direction without getting, red herrings, and we call them false positives, right? Well, okay, maybe this little thing here, a little thing there. And ultimately our eyes are the best, are the best device we have. So just keeping in mind that sometimes more is not more. It doesn't help us more, and it can cause inadvertent diversions down a different path.
And anyone want to talk about, so we've had a bunch of questions on special considerations for parathyroidectomy in patients with inherited or hereditary syndromes. There were a number of questions in the Facebook group over the last week for patients with multiple endocrine neoplasias, and somebody told they had a CDC73 mutation, and kind of how we think about all of this. Maybe Dr. Kuo, did you want to talk a little bit about kind of how do you think about genetic syndromes in patients with primary hyperparathyroidism?
Yeah, absolutely. So every patient who's very young, and I think for most of us, we would say 40 or younger, when they have the onset of this condition, should have genetic testing to see if there is a genetic component to this. Taking a good family history is also really important. So asking the patients if there's any family history of hyperparathyroidism, or being told, oh, I have really high calcium levels or a lot of kidney stones. That to me is also a sort of warning sign in my head that then I have to think, could this be inherited or familial in some way? And so again, for these patients, genetic testing is really helpful. There's a number of different kinds. There's one that I will oftentimes do in my office that is easy to do. Sometimes I end up sending patients to the genetic counselor as well. I think one thing to keep in mind is that there's a lot that we don't know. There are a lot of things that we are learning every day about all of these problems, but there's a lot that we don't know. And because the genetic testing may come back not revealing anything, does not necessarily guarantee that there is no genetic syndrome. It's just one of those things you have to be really thoughtful about. And I think, again, we've all spoken about being really individualized and thoughtful in our care, and this is just one more aspect of that.
And is there a specific type of operation you think about? Some people have said that they have a reimplantation in the forearm. Or do we take all the parathyroids out?
Great question. So if a patient has a genetic or familial syndrome, then all 4 parathyroid glands are going to be affected, regardless of how they appear to us in the operating room. And I think, we've just been talking about how much we rely on ourselves and our expertise to identify what is normal and not. In these patients, you have to know that even if the gland looks normal, inherently something is genetically wrong with it. And so you need to resect 3 and most of the 4th gland, or some people will resect everything and implant a piece of one gland into the forearm or a different muscle. And there's no clear right or wrong necessarily approach to doing that. But it is, again, how we think about and how we prepare ourselves and the patient for the operation.
Great. Sometimes parathyroids are really hard to find or not where we expect them. Dr. Ye, can you explain a little bit about an ectopic parathyroid and what happens when the gland is in the chest or somewhere where we don't expect it.
Yeah, a lot of talk about ectopic parathyroid glands, and just for the people in the audience, that means an out-of-place parathyroid. And you know, I'm sure the first thing you read on the internet about parathyroid disease, for those who even read anything about this, is that they're highly variable. You know, when we're in mom's belly, they start up by your ears and they travel down to your neck, and so some of them get lost. Most of them, 95%, can be found in this general area, can be accessed through a standard 2.5 centimeter incision, most of them, right? And so people have a hard time agreeing on what the definition of ectopic is. I figure ectopic is something you could never have reached, even in the most skilled surgeon in all of history, through a standard neck incision, right? So those are weird things like up by the ears, things down under the breastbone here. You know, for the patients, you're unlikely to have one of those. I think the probability is, I don't know, 2 or 3% maybe that it wouldn't be discoverable through a standard neck incision. So how do you find those? You know, sometimes you find them because you go into the neck and you don't find anything, and you stop and you're like, well, by process of elimination, it's got to be somewhere else, right? You find a couple normal glands in the neck and you fight another day. And then other times, another surgeon has done the failed operation for you. And then you're dealt this hand and you're thinking, geez, maybe it's not in one of the expected locations. You can see those on a CT. For chest imaging, if you really think it's a chest adenoma, that's a great time to get a sestamibi scan, right? Because there's no background signal from the thyroid, which causes some false positive signal up in the neck. And so, yeah, sometimes you got to get your thoracic surgeon buddy and do it together. Or sometimes you're just like, dude, that's where it is. And then they go out, you know, they go through their cameras through the side of the chest and get it on their own.
And so you work with, or others can talk about, you work with another surgeon to do this. Like if you've got something in the chest, does it involve opening the chest? What kind of surgery are patients looking at?
Yeah, I'll just be really brief. A lot of those that can't be accessed through a neck incision or can't be kind of fished out of the top of the thymus through a small neck incision. These days, the thoracic surgeons are going into the side with scopes or robots, and I can't add value in that case, so I let them do it.
So the answer is it's very rare that we need to do to cut the bone, which is historically what we did. We frequently use a robotic approach for that. So it's very small incisions.
I do think there's a role for us in those operations because, like I was saying earlier, we really know what a parathyroid looks like. The chest surgeons, they don't usually. And so I'm usually kind of around to just look at the specimen once they get it out, because there's a lot of, usually a lot of fat and lymph nodes in the specimen that they take out, because that's just the nature of what's in the chest, where these usually like to hide. And so I try to kind of do it with my thoracic surgery colleagues, and they usually appreciate that because they want to know that they've removed the problem gland or glands. So yeah.
Yeah, I would add to that. I've had similar circumstances where a patient has seen an outside surgeon and had a four-gland exploration without any preoperative imaging. And that surgeon removed 3 normal glands and couldn't find a 4th gland. And the patient had persistence of disease and came to me and had imaging that showed a solitary adenoma in the chest. And so now that was the only remaining parathyroid gland. And so I have been a part of those operations. Once they have safely removed the parathyroid gland from the chest using a minimally invasive robotic approach, I will actually, in those circumstances, take a small piece of that enlarged gland and reimplant it, because that is the patient's only remaining parathyroid tissue. And then we can actually put some in the freezer and save it for later, just in case. That's a thing you can do with parathyroid glands.
Yeah, I guess we should explain to the people on the call, parathyroids, they're finicky. Sometimes we don't want them to lose their blood supply, and they do. But one very cool thing about them is if we literally chop them up, we mince them, and we put them in a muscle belly, they will actually regrow, so to speak, and start making hormone again. So it allows us to take away especially in the hereditary patients and genetic patients, knowing that it isn't coming from the area, that we didn't miss some tissue, and putting it in a remote spot. I usually use this muscle here, it's called the sternocleidomastoid. You guys, everyone has it. Mine's a little weaker than it used to be. But and then once you put it in the muscle belly, it gets more some blood supply and actually starts making parathyroid hormone again. So it's a really cool aspect of parathyroids.
And that
We just
actually is
hope-
a great segue to that
Yeah.
question in the chat about RFA for hyperparathyroidism. Can I take that one?
Absolutely. I was gonna say, we want to get to the emerging treatments.
Okay, so I'm going to start by saying parathyroidectomy is an incredibly safe, tried and true, proven technique to cure this disease. So that is what I would recommend for everyone to have an evaluation for a parathyroidectomy, a traditional parathyroid surgery. Some people, for very specific reasons, are too high risk for surgery. Sometimes they're too high risk for general anesthesia. This procedure, if your surgeon and your anesthesia providers are comfortable, can be safely performed under local anesthesia. So that's also an option if the anesthesia is the risk. If there's alternative risk that prohibits someone from having surgery, then it's a very thoughtful discussion about the alternative options. There are a few alternative options that involve ablation or destruction of the parathyroid gland itself from the inside. The key points here are, number one, it must be image localized because any ablation technique involves putting a needle into it and treating it in some way. And so if there is no imaging, if I don't have a scan or an ultrasound that shows me clearly that this is where the parathyroid is, then there's no ability to treat with a non-surgical technology. If there is something identified via imaging, this is the only circumstance under which I would recommend biopsy of a parathyroid. So we do not typically biopsy parathyroid glands. As Dr. Cunnungham mentioned, they can gain a new blood supply and regrow. And so you can actually seed or track parathyroid tissue through the needle, and you don't want to do that unless you need to. And so for these patients, I do a same day biopsy where I have an on-site pathologist who will look at the specimen and confirm for me that it's parathyroid tissue, and then I will treat. My preference is to treat with ethanol, which is alcohol, like drinking alcohol, but incredibly high concentration. So 98% ethanol and a very, very, very small amount injected directly into that gland under ultrasound guidance. So if it's not a parathyroid I can see under ultrasound, then that's not a procedure that I can perform in my office. I do work with an interventional radiologist who has CAT scan capabilities, who I do ethanol ablations with if they're only visible by CAT scan. The key is that the ethanol must be enough to destroy the tissue, but not so much as to break open the capsule. And a parathyroid capsule is very fragile. And so it has to be done thoughtfully and very, very, very small amounts under ultrasound guidance, because if that capsule breaks open, then you have not cured the problem. We know that the cure rates for ablation techniques are lower, much lower than they are for surgery, anywhere from 60 to 85%, depending on the study that you read. And the long-term success is very unclear because most of the patients who are having these techniques were too high risk for surgery and therefore were challenging to follow long-term for other reasons. So I wouldn't recommend seeking out ablative techniques for standard primary hyperparathyroidism in someone who could otherwise have a safe operation, but it is an option for patients who are incredibly high risk, particularly those who have severe disease, hypercalcemia that's impacting their cardiac function, severe osteoporosis with multiple fractures that are impairing their quality of life, recurrent kidney stones that are impairing their quality of life. And so I would consider this a palliative procedure for quality of life intervention in a very highly selected population.
Anyone else want to chime in here? Well, I think we are almost at the hour. This has been a great discussion. I feel like I've learned a lot from all of you and how you do things, and hopefully our participants have as well. We will be posting this on the Facebook page as well as on the AAES YouTube page. And then also in the chat is there are links to the AAES Surgeon Finder. So to remind you, you can search by location, you can search by disease interest, and find a high volume parathyroid surgeon near you. And then also the AAES patient education website, which can be really useful to answer a lot of these questions. So I just want to thank my co-moderator and our panelists once again for a great discussion.
Thank you.
Thank you.
Fantastic.